So healthcare's disparities research is becoming more and more common in surgical fields. And with this, there's been a call for more rigorous and actionable work. We can really no longer ignore the fact that structural differences may be driving differential outcomes more so than one specific intervention that we wish to study. Nor can we discuss these outcomes without naming and addressing things like racism, sexism, ableism, and so on. Although health equity research really didn't begin to mature until the 1960s, it traces its roots back to the early 1800s, with studies looking at social class and health outcomes largely coming out of Europe. The first scientific study of poor health outcomes among Black Americans was a sociological study completed in 1899 by W.E.B. Du Bois. During this study, he mapped the 7th Ward of Philadelphia, and he was able to link poor health outcomes among Black populations to structures of oppression. His work really helped reformulate the idea of race at the time, as he highlighted the fact that social structures were drivers of differential health outcomes and not social pathology, which was the popular opinion at the time, or inherent genetic differences. In the mid-20th century, the field of statistics and epidemiology really revolutionized itself. And during that time, researchers began to look back at mortality trends over the preceding 100 years. And what they found was that it wasn't these advents of modern medicine that really drove declining mortality rates, but it was things that predated that, things like clean water, sanitation, and improved nutrition. And with that, you have the advent of public health. During this time, there were large epidemiological studies being done, which were showing differences in mortality by social class, while others began to call attention to inequitable access as a source of disparities. All of this work has really led people to realize that much of health is not really a result of health care, but instead social factors, which creates gradients of advantage and disadvantage that will affect health. In fact, studies have shown that only about 10 to 20% of preventable morbidity and mortality in the United States is secondary to the health care that we provide, where 80 to 90% is related to social factors, with 50% of this being tied to your zip code. Healthcare's disparity research really seeks to look at the bigger picture of health. It looks to identify upstream factors, which are also framed as the causes of disease, or the social and structural determinants of health, to help us understand what factors determine who gets sick, who accesses care, and who gets well. Identifying these upstream factors that lead to the disparities in outcomes allows for interventions to occur on the population level. And it is known that when we intervene on the population level, we have a greater impact on outcomes than when we intervene at the individual level or on downstream factors. So there's a huge financial benefit to this type of research, but there's also a huge human benefit because people deserve to be healthy and they deserve access to high quality care. One of the difficulties with health equity research is the root causes of inequity intersect and reinforce each other in very complex ways that can be difficult to untangle. And we really need to work to unravel these causes and address this through ongoing research. To date, the early focus on class and economic status really has persisted, with many studies continuing to look at these factors and really these factors alone, while failing to engage into discussions of racism, and then factors associated with gender and gender identity, sexual orientation, and ableism really are blind spots in health equity research due to a lack of adequate data collection and flaws in our databases. So for example, a study in 2020 that came out of Nationwide made headlines across the country as it revealed that healthy Black children undergoing elective surgery had a higher risk of dying than their white peers. And this was an article that I used quite often during presentations on racism and health in America. And inevitably, someone in the audience would say, well, in this study, they didn't control for socioeconomic status, so that must have been what explains this whole differential. It had to be that the Black children were poor and the white children were wealthy. And if you looked at them in the same socioeconomic group, it wouldn't be that way, and you wouldn't have found this outcome, which really kind of opened my eyes to this persistent denial or people's willingness to accept racism as a factor in health. Interestingly, a follow-up study was done by the same group, and they actually did control for socioeconomic status using a different database. And what they were able to find was that the Black children had worse or higher levels of surgical mortality than the white children across all socioeconomic status, such that the most well-off Black child had the same mortality rate as the least well-off white child. And knowing this, it becomes clear that if we focus all our interventions on socioeconomic status, we're not going to do anything to lessen this gap. Overall, health disparities research is really an all-in game. It's a game of harsh truths and difficult conversations. And now we're going to have our abstracts presented and learn more about some of these topics and some of the work that's being done.